Hello, I'm Ros Eeles. Thank you for asking me to present the BARCODE 1 study, Enrichment of Prostate Cancer Detection in those with higher polygenic risk. These are my conflicts of interest. We know that prostate cancer is a highly heritable disease. Twin studies show that at least 58% of the predisposition component is heritable, and this is composed of rarer variants, but the majority of predisposition is due to common variation identified by genome-wide association studies. We now have a very diverse risk profile using SNPs, 451 SNPs, which is applicable to diverse populations. The study of BARCODE 1 was undertaken in the time when we only had a profile that applied to Europeans, but we will be able to repeat this in men of diverse ancestry with the new profile. So what's the problem? Well, the first is that population-based screening is not globally agreed. There's difficulties with PSA. So this gives us an opportunity to utilize other tools. And now that genetics is becoming more accessible and affordable and acceptable in populations, this leads to mass testing as an assessment, which was what we did in BARCODE 1. We used polygenic risk score applicable to the European population, 130 SNPs that inform on the Conti score of what we call 269 SNPs applicable to Europeans. And those at the highest risk of prostate cancer were offered intensive screening with prostate, MRI, and biopsy. We initially did a pilot study in 300 men in London of European origin, undertook a polygenic risk score of 130 SNPs, and the top 10% of the risk strata, that's 25 men, had MRI and biopsy. That led to 18 biopsies, 7 cancers detected, and 29% of those were not at the lowest risk of Gleason 3+3. So following the pilot, we then did the main BARCODE 1 study, aiming to recruit 5,000 men in London, 55 to 69 years, offered them SNP profiling using a saliva sample, and the top 10% of the risk stratum, which is equivalent to at least 2.7-fold risk compared with the average of the population, were offered prostate MRI, multiparametric MRI, and a 12-core transperineal biopsy with targeted biopsy if there was a PIRADS 3 or above, irrespective of their PSA. And these are the initial baseline results of the BARCODE 1 study. And over 40,000 people were invited to the study. And we found that 22% returned their saliva kits. That's much lower than a mammographic screening study. And 745 men were in the top 10% of the risk distribution from polygenic risk score assessment. Of these, 551 underwent an MRI and 468 a biopsy. And this led to 187 cancers, and the median age was 64, and you can see that the median PSA is low. And the majority of cancers did need treatment on NCCN guidelines of at least active surveillance in the intermediate and low and very low risk. But of these cancers, 28 and 12 in the unfavorable and very high risk groups would need radical treatment with either surgery or radiotherapy. In other words, 55% of the cancers detected were above Gleason 3+3, they're 3+4 or above, and 21.3% needed radical treatment. And this is the breakdown of the whole set. And if you look at the 55% that have Gleason 3+4 and above, this compares with 35.3% in the ERSPC screening study, and that's statistically significant. So what cancers are missed? If we look at the prostate cancer by NCCN risk groups, 187 cancers were found in the top decile of the risk distribution from polygenic risk score. If we then look at cancers that have a PSA of greater than 3, the numbers of cancers that were missed were 118 cancers. And if we look at an algorithm of PSA and MRI together, And we look at using the MRI and PSA pathway. 30 cancers were detected and 44% of these were missed using the standard pathway. So the next question is, were we subjecting men to a high risk of overdiagnosis? This is leading to overtreatment of indolent cancers. And so we looked at 3 scenarios: PRS as a screening test, using MRI and using PSA. And this work was done by Nora Pashayan. And she looked at PRS, percentage overdiagnosis, and compared that with screening with MRI and screening with PSA. And you can see here that there's not a much higher incidence of overdiagnosis. So in conclusion, using PRS on a saliva test to guide targeted screening is a one-off test. It uses germline DNA. It finds a high proportion of clinically significant cancers. PSA and MRI miss some significant cancers in the high-risk group. And in comparison with the standard PSA screening study, the PPV is higher. We detect 55% clinically significant prostate cancer. And if you use the standard PSA and MRI pathway, that may not pick up clinically significant cancers. We don't see overdiagnosis leading to overtreatment. And these are baseline results, so we do need follow-up of these individuals. I'd like to acknowledge our funders and the BARCODE 1 team. Thank you.